The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of The Genuine Article, and I have the opportunity to talk to one of my neighbors here in San Diego, Dave Canzari. And Dave, of course, is well known, and he's one of the interventional cardiologists at the Scripps Clinic, and he's the first author on an important paper in JACC dealing with percutaneous intervention for unprotected left main coronary disease. How did this paper come about, Dave?
Tony, thank you. The motivation for this paper is to review the current status for percutaneous revascularization of unprotected left main disease. And it's an important one because it's supported not only by the American College of Cardiology Interventional Council, but it's representative of many of the key clinicians and investigators who have put forth the evidence that currently supports PCI of unprotected left main disease.
Yeah, now recognizing that the guidelines lag behind the contemporaneous data, what are the guidelines at the moment for PCI for left main?
Currently, for most patients who are suitable candidates for bypass surgery, our guidelines recommend as a class 3 indication. That is, they recommend against percutaneous revascularization for PCI. In many ways, these recommendations are formed or based upon outdated data, largely due to patient selection issues, perhaps not representative of the patients we consider today. The current evidence, however, really has placed us at a state of equipoise. And in particular, consistently across all of the comparative trials, the outcomes of death, of myocardial infarction, and of stroke, even through long-term follow-up, are really no different, both clinically or statistically, between surgery and PCI.
Yeah, I guess most of these studies, though, have been retrospective observational studies. There has been syntax, but I guess there is a need for more randomized prospective data.
That's absolutely right. We currently do not have the supportive evidence or substantive evidence to take us from a class 3 indication to something potentially like a class 1 indication. We don't have, in particular, any prospective randomized data, with the exception of 2 very small studies that are really inconclusive with regard to the outcome. Most of the data, as you mentioned, is based on observational studies and statistical modeling, like propensity score modeling. But the good news is that forthcoming is a very large randomized trial. It will be a multinational trial involving more than 2,500 patients to more definitively, I think, settle this issue of PCI versus bypass surgery for left main.
Yeah, now does the lesion severity, the lesion type make a difference?
Absolutely. Osteal or shaft disease within the left main has a very, very favorable long-term prognosis after percutaneous revascularization with drug-eluting stents. More common, however, is bifurcation disease. And especially what is a determinant of outcome for left main patients is the fact that isolated left main disease is uncommon. And more commonly, we see it in association with 1, 2, or 3 vessel disease. And so more likely than not, it's the increasing non-left main lesion complexity that probably influences outcome more than the anatomy of the left main itself.
Yeah, interesting. And I guess the issue of post-treatment antiplatelet therapy will be an important one here as well.
I think there are many still outstanding dilemmas for us after treatment of percutaneous left main disease, and that includes this issue of dual antiplatelet therapy. Yet we know that the long-term risk of stent thrombosis in the left main setting seems to be unusually low relative to other non-left main lesions. The other issues include the patient selection, as I've implied, with patient complexity. How do we follow these patients long term? Do we do follow-up catheterization, CT angiography, or just follow them clinically? And issues of cost effectiveness relative to surgery must also be considered.
Well, it's clear that with drug-eluting stents getting better and better and with better patient selection, that PCI for left main really is an alternative that has to be examined. And until that large randomized prospective trial is done, this state-of-the-art manuscript in JACC, I think, should provide considerable direction for cardiologists. For The Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.